Good afternoon. It's about noon. We'll give a few more minutes for people to come in to this presentation. We can start out with the announcements. Today is October 7th. Welcome to our first webinar in the RRHIMA Fall 2025 webinar series. Please note an email from Zoom with links to the video recording, presentation slides, and the evaluation form will be sent to you tomorrow at noon. Once you complete and submit the evaluation form, you will get a link to the CE form. Please print or download the CE form immediately. Friendly reminder is that if you have already registered for this webinar series, please do not register again. The next webinar in our series will be Tuesday, October 21st at noon. The topic is HIT program, student learning objectives, and the new focus on competencies and performance indicators in a hybrid competency-based education model. Our speaker will be Erica Madison from Alfred State College. Look for a reminder in a Zoom invitation the day before the meeting. Check your email or the event calendar on the RRHIMA website for the most up-to-date information and scheduled events. Next Tuesday, we have our fall business meeting from noon to 1. Everyone is invited to attend. And today, our speaker is Anastacea Alexander. She is an RN clinical documentation integrity practitioner. She is also a registered nurse who has been in the healthcare industry for 25 years. Her jobs include managing a team of clinical documentation specialists, maintaining a CDI program with KPI, including compliant inquiries. She also educates physicians, both residential and hospitalists, by building and presenting dictations, I know I said that wrong, on various topics. Anastacea received her associate's degree in the science of nursing from Ocean County College and went on to receive her bachelor's of nursing from Chamberlain University of Nursing. Fun fact about her, she lives on a 6-acre chicken farm with over 200 chickens in Pennsylvania. With her husband, they have 2 teenage daughters and 4 dogs. And welcome, Anastacea.
Hi, thank you so much, you guys, for the introduction. I'm happy to be here. I want to talk to you guys today about a presentation I usually deliver to hospitalists and residents. Along the way, we have taken some surveys and found that with all the education that providers get, they do not receive education, or at least education that is more formal in nature on how to document. And so I just want to talk to you a little bit about today about basic documentation and how to write an H&P. I want to do more of a high-end presentation because you don't need to know everything that the provider potentially needs to know. But it is important that we review, what the expectation is for them so we know what to look at from an HIM and a coding standpoint. So we're going to look at clinical documentation, the basic documentation, provider documentation with key drivers and clinical terms to diagnostic terms, coding, reporting, funding. We're also going to look at history and physical documentation and the goals of the H&P and the components for. And then why is documentation so important and being complete? Definitely the goal. So electronic health records, they improve that patient care, right? They're the communication tool that is utilized between providers. They increase the patient participation. They improve care coordination. When is the patient going home? What do they need? They improve diagnostic and patient outcomes. They also help to practice efficiencies and cost savings, which I know is a main concern, not only at a state level, but a government level as well. Now, clinical documentation, it's transcribing all of those conditions and diagnosis related to the patient's episode of care. Why were they admitted? What were we treating? What happened with them? The documentation reflects that patient in the bed. At the end of the day, those ICD-10 codes really have to paint the picture. The necessity of that clinical diagnostics, like why did we need that x-ray? What prompted that CAT scan? The standard of care provided. Once we get a diagnosis, standard of care is really important in describing whether the patient was cared for appropriately. The need for that continued length of stay, why were they in our hospital so long? And that quality of care that was provided. How well did we care for them overall, and what happened to them along the way? So documentation is like that form of communication. It's also a legal document and a document of service. And the legal system looks for it to make sure that we haven't had a significant breach of or a deviation from that standard of care. Standard of care is the degree of care a prudent and reasonable person would exercise under the circumstances. Physicians should be documenting their clinical judgment and decision making so that their treatment can be understood. A lot of doctors don't feel confident about putting in their rationale for why they ordered a test or why they thought what they thought based on clinical indicators. What we train them to do is to make sure they're adding those clinical judgment and decision-making parts of themselves within the documentation so that if they ever had to look back on it, they would know what they were thinking at that time. It just makes for well-rounded. It also helps anybody who's reading the documentation, whether it's the patient, whether it is, another healthcare provider. It helps them to understand where that physician was what they were thinking and where they were at with it. So we look for 3 sovereign principles of documentation, right? Who is document the patient's capacity to participate in his or own care. What and when is using clinical judgment, identifying the decision-making process that goes into treatment decisions. And then the why really is recording the risk and benefit analysis and including both the risks and the benefits of each intervention, writing down their own thoughts as necessary. When we look at basic documentation broke down further, we're looking at taking that subjective data. Subjective has to do with the patient's explanation of what's going on, and the objective findings, which is really the tests and the assessments that we as the providers have addressed. To document the assessment, it's also known as the diagnostic impression, by defining the working diagnosis, usually diagnostic terms, to create a plan of care or treatment and then reassess that daily. We talk about SOAP notes, which stands for subjective, objective, assessment, and plan. And on each of those follow-up visits, the doctor should be indicating what's the next steps, what's the expected outcome, why would further testing be needed. So when they're documenting, we teach, hey, all of this is incorporated or inclusive in this. So the subjective always describes the patient's current condition in a narrative form. It's the patient's chief complaint. It includes when it happened to the patient, how bad it was. It's important to document what the patient states and they are feeling in their own words. This is where a lot of the doctors you'll see use quotation marks. Objective is really the tangible, measurable data, right? It's your vital signs. It's what observations you saw, whether somebody had an increased work of breathing. It's the physical exam and literally listening for wheezes on auscultation. It's those laboratory findings, so that tangible evidence that you can get from tests and from assessments. And that's the objective data. The assessment really summarizes the salient points of the primary medical diagnosis. If the diagnosis has already been made, you comment on whether the patient is clinically improving or deteriorating. An impression is maybe a resolving community-acquired pneumonia. A complete list of all the diagnoses and issues should ideally be completed in this section every 1 to 2 days or whenever a new issue arises. This is extremely useful, especially for after-hours staff who may need to rapidly assess a deteriorating patient. So we always talk to them about, make sure your stuff is updated. This cut, copy, and paste nonsense is for the birds, right? The plan. So you document a clear plan, including the further investigations, referrals, procedures, new medications charted, old medications that are in place also, and are they effective? If not, why? If not, what are we going to do about it? If possible, include the estimated discharge date, which really helps those case managers to determine when the patient's going to be discharged. So when we don't forget to document, right? Phone conversations and family meetings. We teach this for a reason because there's been so many times where phone conversations have really made the difference. Maybe the doctor unearthed a critical component. I'm sure some of you guys have watched the show House, where he sends the residents out to really find all of the critical pieces. Maybe there was mold behind the sink, maybe there was something. Those phone conversations documented can uncover clues. Family meetings also, these help to determine where the patient is going, if somebody can or cannot care for them, what the barriers are to discharge, and also, what has been up with the patient who maybe can or cannot speak for themselves. So documenting these are very important as well. So the goals in documenting that we talk about to the doctors is translating those clinical terms to diagnostic terms. We all know that coders cannot infer a diagnosis. They have to have it spelled out in black and white. When the doctors just continue to use clinical terms, we see that often here in the ICU. And on the med-surg floors, you get more of the diagnostic, because the ICU actually documents by systems as opposed to priority of the diagnoses. So we have to remind ICU providers, hey, take those clinical terms and give me a diagnostic term associated with it. And we all know that possible, probable, likely, suspected, those terms we can actually code if they were written in the discharge summary, or they were written all throughout, and maybe doctors don't have a definitive answer at the discharge summary. We can still code possible, probable, likely, suspected as though the diagnosis existed. So that's important for them to really use their clinical knowledge and their ability to utilize the science that they have been trained to look at the clinical picture, understand the body, and see what is really going on here. So doctors are the authors. The provider documentation is the key driver to a lot of things, right? Physician communication, the improvement of quality of care, the defense against malpractice, regulatory compliance. How well did we treat a patient for sepsis? Did we give the TPA under the allocated timeline for a stroke patient? Organization and provider profiling. How well are we doing as an organization? How well is that provider doing? Accurate representation of severity of illness and the risk of mortality. Justification of medical necessity, correct resource utilization, denial prevention, accurate reimbursement, high patient satisfaction. Provider documentation is the only thing that they have to write down the experience that they had in treating the patient who's in front of them. And they have to be able to capture the presentation of the patient. And then those patient records then get turned into clinical coding, and the clinical coding goes to hospital data, and the hospital data gets to reporting, and the reporting gets to funding. And I always like to say that the doctors are the authors and the coders are the publishers, and we as CDI are the editors. We're editing it. We're being the bridge between the authors who speak in clinical jargon and the coders who speak in coding language. We're the bridge to try to speak both languages and have them come together to have the most complete charts that are possible. Because at the end of the day, the clinical picture is reduced to codes. Now, do you see this dependence on wheelchair? Does anybody know why it's so important for the social determinants of health to be included in the ICD-10 codes at the end of the day? It's because non-medical factors account for 80 to 90% of a person's health outcomes. It's truly not fair to document somebody as being a non-compliant patient if the reason they're non-compliant is because they don't have a house, money, or food to go get those diabetic medications. You have to paint the complete clinical picture, and adding in like patients dependent on wheelchair, patients homeless, patient, has issues with money. All of those social determinants of health codes that really paint that picture of why the patient is the way they are. It also allows the next level care provider to understand maybe there's some resources that could be provided. It can gear a case manager into, hey, maybe we need to refer this patient who's homeless into a facility to receive treatment for their osteomyelitis because they're either that or they're not going to get treatment and they could die. So all of the entire clinical picture getting reduced down to ICD-10 codes is really, really important that we capture everything in the record in a complete manner. So that reporting at the end of the day, that impact, all right, the provider documentation, it's the profile in the public eye, it's quality, medical necessity, gets to research, gets to appropriate payment, and it gets to compliance, it gets to public health surveilling and reporting. The reason I like this one so much, this epidemiology piece, is I recently read that if the doctors are writing in both the outpatient and the inpatient settings, they're documenting everything that they're treating and everything that's going on with the patient in a very holistic sense, and then we capture it in those IDC-10 codes. It helps FEMA, for instance, in the case of an external disaster in our area, to know how sick the public is around us. How sick is our community? What supplies would be needed for our community in the event of an emergency based on those codes? So I always look at what the doctors do as taking care of all of us, not just the one patient. And what the coders do at the end of the day is really help to then also take care of our entire community, not just that one patient. So I always look at you guys as heroes in a big sense. So reporting data, right? All data from the documentation is turned into codes and then it goes everywhere. Insurance companies, reporting agencies, hospital value-based purchasing. We hear a lot of that meaningful use data, HCAP scores, how good are we as a hospital provider? Many of the participants have a role to play in the revenue cycle, which is that financial piece that gets to the funding, right? So as a provider, the role is to employ their specialized knowledge to document the complete services and patient interactions in the EHR. And we found that two of the most sobering findings is 86% of denials could have been avoided. We get a lot of denials. Nearly 1/4 of those are never recoverable. So, I mean, if we think that adding something like hypomagnesemia could add maybe $1,500 to a chart that ultimately covers the cost of the lab tests that were run and the IV piggyback 2 grams IV mag sulfate. Without that, without those diagnoses, without some of this stuff being documented accurately, we not only lose out on the money, but we pretty much did the work for free. And funding is what keeps our doors open so that we can help the community further. So the more that we get the documentation correct, the more we get the coding correct, the more we get the reimbursement correct, the more we can keep our doors open, the more we can grow our services for the community, the better job we can do for our patients. So it really comes down to documentation. So everything starts with good documentation. Let's switch gears for a minute and talk about the history and physical. It's defined as the most formal and complete assessment of the patient and the problem. The goal of the H&P is to gather information about the patient and medical concerns and provide a detailed overview. They're to paint the picture of the patient's health and the needs to streamline the treatment plans that encompass that standard of care. What does the H&P do really? It works as a communication tool for patient safety to help inform other practitioners, including nursing staff, what the focus of the care is. It needs to be considered, it needs to be a concise write-up with your thought processes documented in a logical and organized manner to show quality of care expectation. It works as an authorization tool for utilization review to validate the need for the admission, to obtain insurance authorization. And it leads the CDI and the coding staff to what diagnosis is the focus of the stay, helping to define the primary diagnosis, or how we look at it informally as what bought the inpatient stay, what bought the bed. The history and physical, the components are pretty long and extensive. The history of the presenting illness, the past medical history, medication allergies, review of symptoms, social history, family history, physical exam, those lab and other studies, the problems list, the discussion, assessment and plans, style, resources. All of this has to be encompassed in that one document. And if we look at the history of the presenting illness, it starts with that subjective data, and it comes from interviewing the patients. You can see a lot of times how residents, and you see it on a lot of the TV shows, how residents go in and they get the first year has to go in and do the grunt work, and the grunt work is interviewing the patient and asking them why they're here, and gaining those components that are required for that H&P. Well, it includes the chief complaint and the appropriated dimensions of cardinal symptoms. We use old carts or Socrates as it gives them an understanding, if they can memorize those, as to what to ask off the cuff to the patient. And the chronological story begins at the baseline state of health and incorporates elements of the past medical history, the family history, the social history that are relevant to the story. And those review of system questions pertinent to the chief complaint are included. They are really reflective of any other signs and symptoms that the patient might not have thought about. The resident provider or the provider asks the questions to trigger, hey, has this been occurring? Because sometimes those minute signs and symptoms actually help the provider understand the bigger clinical picture. So the HPI reflects the knowledge or differential diagnosis, and the HPI narrative flows smoothly in a logical fashion. The chief complainer subjective data is reported by the patient. It could be a symptom, a condition, a previous diagnosis, or other short statement that describes why the patient is here today. It is essentially the title of the paper. So if you look at the H&P as like a big thesis paper, the title of the paper is really the chief complaint. It allows the reader to get a sense of what the rest of the document will entail. Examples are shortness of breath times 4 days with hemoptysis, right-sided chest pain. As example, the patient may have multiple chief complaints. Their first complaint may not be the most significant. The physician should encourage patients to state all of their problems while paying attention to details to discover the most compelling problem. They're supposed to identify the main problem, and it must occur to perform effective and efficient diagnosis. The HPI is the history of the presenting illness. It begins with a simple one-line opening statement that includes the patient's age, sex, and reason for the visit. And I'm sure you've all seen these, right? This is Mr. Sean Monarch. He's a 56-year-old gentleman. He's got a recent diagnosis of pneumonia. Continues with his outpatient prescribed antibiotics. He presents here today with a 4-day increase in his symptoms of shortness of breath, hemoptysis, right-sided chest pain despite. And those acronyms often for the HPI are old carts. And I put them in here because I wanted you guys to see them, what's being asked, right? The onset, like where did the chief complaint begin? The location, the duration, the characterization of that chief complaint. Is there anything that alleviates it? Maybe some of you guys have been to the doctors yourselves or an inpatient stay and you remember hearing some of these. The reason that they're being asked is for you to trigger anything that you might not have said to the doctor so they can understand the full clinical picture. Does it radiate? Is there a temporal factor? Does it get worse at a certain time of day? Severity and scale from 0 to 10, right? Or 1 to 10. So it's important for clinicians to focus on the quality and the clarity of the patient's notes rather than include excessive detail. So they need to put this in more of a smaller avenue, but take into account everything. So it's the way that they write all of this down is very important. Socrates is the other. That's site and onset, character, radiation, associated symptoms, timing, exacerbating or relieving factors, and severity. You can see that Socrates and old carts are almost asking the same exact thing. It's just a way for the doctors to remember in this acronym what the questions are they should be asking the patient. So our history, right? Our pertinent current or past medical conditions, our surgical history is them trying to include any surgicals and the year. They're supposed to actually put down the year the patient had a surgery done. A lot of the problems lists in places like Epic as an electronic health record will allow for that date to be placed. Family histories, right? If mom and dad both died of a heart attack, you know, we might be looking at having a bad heart ourselves as a hereditary issue. So getting that family history is really important. The social history acronym could be used here as HEADS, which stands for the home and environment, education, employment, eating, activities like drugs, the sexuality, suicide, depression. This is also where social determinants of health fit in. Do they live alone? Do they work? Do they have food, transportation? Our review of systems. These are the patient answers to get the full picture. So this section is, and it's totally different. The review of systems in an H&P is totally different than the physical exam, which looks again like a review of systems. And this is where a lot of our residents have questions. They look at the review of systems like it's like their head to toe assessment. It's really not. This is a section of an inventory of body system designed to uncover symptoms not directly related to the primary complaint, which the patient may not have initially mentioned. This is like their sleuthing, right? The review of systems are written and verbal questions and answers relevant to signs and symptoms the patient is experiencing at the time of the service. Statements written by providers usually begin with patient states. So per the Centers of Medicare and Medicaid Services, the ROS contains 14 review of systems. So they're supposed to add all 14 in their documentation based on CMS, okay? So if we don't see all 14, and we have seen that here where some of the templates need to be changed because the review of systems is not housing all of this, or maybe one is missing. A lot of times we see integumentary system missing, which we're not sure why we would miss that, because if a patient has a wound, they can tell you about it. But we've gone to great lengths to try to ensure that we are as compliant as possible. So review of systems could look like this, right? It's pretty convoluted, like assessing signs and symptoms of fever, chills, weight loss, malaise. Do they have ear, nose, and throat issues, cardiovascular, respiratory issues, GI issues like a bloating or constipation, change in their bowel habits, the GI, like are they having frequency and urgency? What about musculoskeletal? You've been having any pain or weakness in your back? Integument, again, gets to the lesions and the rashes and such. Neurological, psychiatric, all of these different questions, you know, are what the doctors are going to sit and talk to the patient about. Now, I don't know if you guys remember, but I do because I've been doing this for 25 years. When we used to have medications written down, there always had to be an associated diagnosis. It made life so much easier. Why are we on lisinopril? What are we taking Cymbalta for? What's the Nexium being used for? Every time they had a current medication, there was supposed to be an underlying diagnosis associated to understand why that was being ordered. So here are some examples, right? Like Motrin 600, 4 to 6 hours, moderate pain related to this right arm fracture. Nexium was for GERD. Lasix is, you know, for this chronic systolic congestive heart failure. Getting diagnoses that are as specific as possible gets us to the right ICD-10 codes. The IDC-10 codes now can go out to a 7th character. I mean, we have to be pretty specific. So it's good that the doctors wouldn't abbreviate any medications, and it's really good if they document the medications, the allergies, in the subjective or objective sections. How to document allergies. For any allergies, they should put the nature of the adverse reaction, like penicillin was hives. They're supposed to note whether it's mild, moderate, or severe. Objective data is factual information that professionals gather through observation or measurement that is true, regardless of the person's feelings or opinions of the person presenting or receiving the information. So objective data is just the facts, man, right? When we got the x-ray, what did it read? It doesn't, that I think that something is there. That's not what objective data is. Objective data is just the facts. So it's the vital signs, the height, the weight, the BMI, the physical exam findings, the lab results, imaging results, other diagnostic, and then the recognition and review of the documentation of other clinicians. And why is that last one important? If you're going to consult in infectious disease, is what I always tell my docs. If you're going to consult in wound care, if you're going to consult in, look at what they're writing. Don't just consult them in to consult them in and then ignore what their recommendations are. Make sure that they document that the doctors are looking at whoever is the consulting person coming in. If for no other reason than out of respect, right? Our physical exam, actual visual hands-on findings that the provider sees, hears, or measures upon the examination. We understand that the pathophysiological mechanism of the physical abnormality is essential for the correct diagnosis and the management. So they need to look at what did they see when they physically examined the head and neck, the lymph nodes, the cardiovascular, lungs, breast, abdomen, skin, multiple, like what were they finding upon physical exam? Nursing documentation, this is where I wanted to stop and say that nurses, aides documenting, that gets to nurses documenting, that gets to physician documentation can help this whole process. It can also lead to more of a focused assessment, which is good. So we always begin with our vital signs. We always look at temperature, pulse, blood pressure, respirations, pain. One of the things that we're noting is sometimes these components are missing. If we're calling it sepsis secondary to pneumonia, but we're missing the temperature and the respiratory rate, and we haven't got a full set of vitals, and the pulse ox is maybe unclear, or maybe nobody documented how many, whether it was room air or nasal cannula, that's huge in trying to understand like exactly where the patients are. We need the full set of vital signs in there. Why document the BMI? So as a coder, you guys can document obesity or morbid obesity only if it has been written. You guys can put in the BMI, right? We can put in but we have to get the doctor to physically write obesity and morbid obesity, which adds this to the severity of illness or the risk of mortality, depending on how bad. Let's see, why would the documentation look like? Okay, so includes diagnosis in clinical terms, and then interventions in education. So diagnosis number 7 may read morbid obesity as evidenced by a BMI of 42.9, placed on a carb-controlled diet. The dietitian was consulted, placed to decrease risk factors, educated patients on the benefits of a healthy weight and risk factors associated with the morbid obesity. So I try to let the doctors know that this is important. Now, we have had recent call-ins from an HIM standpoint where patients have said, take that off my diagnosis. I don't want that on there. This is not a punitive diagnosis. This is based off of a BMI. It's based on objective data. When is it important to associate a diagnosis with an abnormal lab? It's when it increases the intensity of the services necessary to provide the patient with excellent care. So what does that look like, really? That's example of this is H&Ps to discharge summary. So if you have H&P that says hypomagnesemia is evidenced by a MAG level on 1120 of 1.6, where they gave 4 grams of mag sulfate, and they're going to continue to monitor. They get to the next day, the MAG levels now normal at 2.3. The discharge summary could say under the secondary diagnosis, hypomagnesemia resolved, with a blurb noted in the hospital course, like hypomagnesemia was noted during the stay, which resolved post Repletion with mag sulfate level at discharge was 2.2. They're showing it. We started off with a lower level, which may have been attributed to some of the patient's signs and symptoms, as magnesium can actually work for their contractility of their muscles. This becomes really important when we've done something about it, for one, when it's added to the monitoring the time frame. Time is the biggest commodity that the physicians have, that they put into the cases. So even if it's not that we gave a magnesium, it's the doctor took the time to look at it. Wound care nurse notes. There's a location on the right heel and it's a stage 2 in healing. And a lot of times they'll put their recommendations and then they have a narrative and whether they referred them to dietary or not. I like that RRHIMA has a tips for documentation, and I give this around to the physicians a lot. Documentation of pressure ulcers must be done by providers and must include the present on admission versus not. I love this, and I don't know if any of the coders out there would love this too, but it is the diagnosis and procedures can be based on the following provider documentation. And we have what we can get diagnoses from, and the federal regulations where coders cannot infer diagnosis from here. And the difference gives us as CDI a place of focus of where do we need to be predominantly looking for things that coders cannot infer and that may not have been documented appropriately. And I use this a lot. I've given it to my CDI staff. I've also given it to the doctors to say, if you get pathology reports that say the patient now has cancer diagnosed, you need to put it in the documentation. If it says pneumonia, we can't just show that the CAT scan showed a pneumonia in the right lung. You have to write it. The BMI, you have to write the obesity, the morbid obesity, the staging. So the codings can get from the wound care notes, they can do the staging. They can't do what type of a wound it was, or the location has to be written by the provider. Any of the diagnosis associated with medications or orders, conflicting progress notes, when there's conflict in the chart, is the coder going to send a query or is the CDI? We just recently merged with Cayuga from Arnot, and our coders at Arnot have always just sent a message back to CDI staff, hey, could you look at this chart for this? And we send the queries out. RRHIMA rules state that whoever manages any of the queries going out the door needs to make sure that they're compliant. So if you have coders that are sending queries, there should be a random sample done that shows exactly how compliant are the queries going out the door from either CDI or from a coding standpoint. Those things are really important. So assessment and overview. So this section documents the synthesis of the subjective and the objective. If we bring that evidence together, what differential diagnosis do we arrive at? It's an assessment of the patient's status through the analysis of the problem, possible interaction of the problems, and changes in the status of the problems. So the elements include the problems list, the list of problems in order of importance, mainly for outpatient, right? If anybody does coding for outpatient, you always have to have the primary diagnosis listed first, and everything has to be kind of listed in order of importance. The differential diagnosis, this is a list of different possible diagnosis. We see this mainly in the emergency room documentation, where they'll say it could be this, 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 and this, and this, and we're going to work them up to make sure that they're safe. Going forward, the problems list. There's two types of problems lists. The one in the H&P, where you would list out your differential diagnosis by the inpatient problems list as short-term encounter. So this is listing all the problems, the most important first. You will use this to begin and combine the lump problems and then create an assessment and plan. Like problems list, chest pain, fever, shortness of breath, all of these problems. But then there's also the one that EPIC refers to as the ongoing list of diagnoses that the patient has accrued over time. The reconciled list post encounter long term. So you have one short term and one long term encountered problems list. The one that's in the H&P is your short term. It's what are we seeing right now? And then adding to it, what is also past medical history? The one that EPIC refers to a long term is a summary list of the patient's current and past health issues, including chronic conditions, diagnosis, injuries, other factors that may be affecting them, include when the issues occurred and then when they resolved. And this gets to like really a timeline of the patient over a period of time. It gets to what is relative today and what has happened to them in the past. This is what's happening during the encounter. A problems list in the H&P is the focus of what we are treating during the stay, right? Suspicion of an embolism with hypoxia because of the shortness of breath and the chest pain, and maybe it's a presumed community-acquired bacterial pneumonia. Diagnosed as in Rochester, maybe it was, put on somewhere else. The iron deficiency anemia. Is it nicotine dependent and abuse with cigarettes? Is it morbid obesity because of a BMI? Is it hypomag, stage 2 right pressure present on admission? History of GERD suspicious. In the H&P, you're not supposed to know 100% of everything that you're treating at that minute. You're supposed to have evidence of what your suspicions are, what you're presumed to be treating, and why. So I always talk to the docs about, like, some docs will say to me, I don't know what's going on when I'm doing the H&P. I'm gathering data still. That's fine, but you need to incorporate all the right components. Differential diagnosis is not an official diagnosis. It's the step to determine what could be the possible cause based on the symptoms. It occurs when the symptoms match more than one condition, and additional tests are necessary before they can make an accurate diagnosis. Order your differential to reflect the most likely diagnosis or most serious diagnosis first. So we always talk to the docs about what is in their differential diagnosis. And that difference between the differential and the working. In the H&P, your problems list is your list of patients, patient issues, signs and symptoms where you note the differential, the list of possible conditions that could be causing a patient's symptoms, while the working diagnosis is the most likely diagnosis, or the list of potential diagnoses the doctor thinks needs to be. By the end of the stay, there really should be some sort of an inkling of what you just treated, and whether it's resolved, ruled out, whether it's resolving, whether it's still ongoing at the time of discharge. It tells the next level care provider exactly what to treat, what to look at, what's going on. The synthesis summary is taking all of this, and you see the highlighted, this should be listed in each one of those synthesis statements. In summary, it should look like, in summary, the patient always said, we said gets to the subjective data, right? With a history of is your objective data. Who presents with is your chief complaint and what's going on in the presentation. And it synthesizes it all together. Everything that we just looked at gets to, in summary, the patient's 45 with a history of tobacco use and a history of CAD, presents with this. So you're bringing that all along to say will be admitted to the telemetry floor for further diagnosis and monitoring. It's taking all of that and building it and putting it together. The definition is by the uniform hospital discharge data set. So primary diagnosis is the condition established after study to be chiefly responsible for occasioning the admission. And the example could be like a code 43 intractable hemorrhage with as PDX, with a code 348.5, which is cerebral edema, as an additional diagnosis, defending these codes with all of this when they're writing their problems out. And that comes from ACTIS. The plan, this section talks about the additional tests and consultative. What are we doing about everything? It state which testing is needed, what the rationale is, the therapy needed, the specialist referrals, the consults, the patient education and counting. It's the comprehensive SOAP note has to take into account all subjective and objective information and accurately assess it to create the patient-specific assessment and plan. It's important to focus assessment as evidence of the H&P, so they want to have a focused assessment. If we know the problem is respiratory failure, but we're really not doing a good job looking at the pulse ox and where the patient's at today, are we really doing the case due diligence? So we need to have a focused assessment. If the main idea is a respiratory failure, it needs to be that we are assessing this every day. Thresholds for completeness. Providers are reminded to ensure that their notes meet the threshold for completeness. For example, poor quality might be a 42-year-old female admitted for somnolence and abnormal drug screen. It's missing clarity. What's the diagnosis, right? High quality would be admitted with drug dependence and intoxication of oxy, as evidenced by a positive drug test for opioids. And this comes from a RRHIMA. I always teach them, don't drop your diagnosis. That drives us nuts. They might have sepsis written like 2 and then the sepsis was resolved, but nobody writes that. They just drop the diagnosis. That has been very not helpful. Specificity, always document to answer what type, what acuity, what location, what infection, those linking languages. Was it E. coli UTI that was caused by the Foley catheter that gets it to a cavity? That cause and effect? Did the surgery cause that acute blood loss anemia? Is it a complication code that we should be adding in? I mean, we've got codes for everything now, right? So the conclusion is, so why is the documentation so important? The documentation really promotes good patient care, quality of care, complete and accurate medical records to help ensure patients get the right care at the right time. And at the end of the day, the patients are what really matter. Good documentation also can help avoid liability and keep out fraud and abuse trouble. If the records do not justify the items or services for which are billed, we might have to pay the money back. That comes from the Office of Inspector General. Why is the documentation so important? It can lead to better patient safety and patient care through communication. Doctors spend less time trying to figure out complex insurance guidelines. They can focus more on patient care. If they're complete in how they chart, it can decrease readmissions. It can improve mortality rates. It can get the patient the care that they need so that they're as compliant as possible. And also noting that the patient can take care of themselves and that they understand the discharge summary at the end of the day. They understand the discharge instructions at the end of the day, that they're capable and that they've had a return demonstration on, say, a new insulin that needs to be given. Those are huge in preventing readmission and improving those mortality rates. And they improve workflow. It improves communication between providers, patients, staff, medical billing, coding, right? You guys need to know what's going on. It increases the faster service and fewer insurance issues, the word of mouth, whether we did a good job or we didn't, those fewer denial claims. Oh, I hate denials. I'm not kidding. Utilization management, documentation, improved strategies. It can reduce the number of claim denials, can improve hospital revenues, can lead to an increase in patient services. And it funds our hospitals to keep those doors open. So proper reimbursement for the hospital system starts when you document and to paint the clinical picture and the story of the patient who entered our doors. That gets to our coders coding the entirety of the clinical picture at the end of the day to do the same. Again, the clinical picture is reduced to those ICD-10 codes, and coders can't infer a diagnosis or components of one. Everything starts with good documentation. So any questions and answers that I can help with? And I appreciate you guys letting me be here today.
Thank you, Anastasia.
My pleasure.
Denise says, great presentation.
Thank you. Anybody have any questions? Anything I can answer to try to help? Because when a patient comes in, I see in here, it says, when a patient comes in with a subjective complaint of painful urination, but defers a PE and the provider orders UTI testing and uses an R code of unspecified symptoms and signs involving the genital urinary systems as the PDX, it is appropriate to replace that non-specific code with dysuria. If I would tell you that if a symptom code is not turned into a true diagnosis and you're not to infer, I would say that you would query the symptom. We actually have a template to query a symptom to get it to an actual diagnosis that's a specified diagnosis, so that we're not just putting in more symptoms. We like to have the codes be as specific as possible. And we pride ourselves on educating the doctors that unspecified diagnosis need to be specified. Does that help? Anybody else? Let me see if there's a couple more in the chat. It looks
We do have a question. As coders, we have been coding from the pathology report. I just want to know where I can read more about this.
I can get you the literature about the pathology report and send it out to the RRHIMA team. It just take me a little time afterwards to get it around, but that's a really great question. Let me get to the pathology report. Yeah, because my understanding is that's one of the areas where you cannot just automatically, the doctor actually has to write the diagnoses. So I will send that back around to the team. There's another one. How do you get your time in front and from the residents? How do you get them to carve out time for your presentation? So what I do is I meet with, there's a resident didactic liaison here at Arnot. I've also gone to the heads of the, we have a head of the hospitalists and a head of the residents. We have a head in family medicine, different from a head in internal medicine. And I've gone to all of them and asked them for time. And once I start presenting, and a lot of this, they have found the value in it. They were skeptical at first, but they found the value in it because the residents are getting so much better with their notes. They're getting more confident in how they're diagnosing and taking those clinical terms and turning them into diagnostic terms. So taking the time to find out who the key players are and making sure that I'm on a didactic schedule is huge. And then anybody who does not make my presentations, I have sent them the PowerPoint slides. And I have also done one-on-one. I have an open door policy and an open house where the doctors come in when they feel like it and they say, hey, I have trouble with this. Can you sit down with me? And we do one-on-one times. I also have taken my my computer downstairs to the didactic room where a lot of the providers do their documentation at the end of the day, and just said, hey, let me help. Like, what can I do to help answer the queries? What can I do to help with anything that you're having trouble with? And then we in CDI have a lot of the resources that maybe the doctors don't have. And we're given it because of ACTIS and AHIMA. We're given it in a format that is so much easier than what the providers get. So being able to provide those resources is huge in gaining the confidence of the resident and for their own documentation to be as accurate as possible. And it's been really great, just so you guys know, because we've had residents that have taken the ball and run with it, and they are sitting down with other residents that are below them, and they are saying, hey, I see you're struggling, let me help. And it's based off of what we've educated them on. So is there any other questions? And that was, okay. Any other questions I can help with, you guys?
Well, I have unmuted Karen. Karen is our first year director of education. I just wanted to introduce you guys to her today. And thank you again, Anastasia.
Absolutely.
So Karen, you can just unmute.
Hi, everyone, and thank you so much today, Anastasia, for that great presentation. And hopefully the membership enjoyed it. I did. It was very informative, and I look forward to many more to come for the next few years. And Melissa, you did a great job. So
thank you.
Thank you very much.
Well, that ends our presentation today, unless someone else has another question. Thank you guys, and hopefully we'll see you at our business meeting next Tuesday at noon. Have a great day.
You too. Thank you.
Thank you.
Thanks, Anastasia. Bye.